So my thanks to both Dr. Knox and Dr. Bond for the wealth of information they brought you. We have about a half hour for questions. If you have had occasion to write some down already, again, just hold them up at any time in the next half hour, and we have a couple of our volunteers who will be happy to bring them forward. There were questions that were submitted in advance, and I want to just get my list of those questions. And I'll begin with one, and I probably will direct it first to Dr. Bond, but certainly Dr. Knox, feel free to join in comment. It's with respect to the lack of treatment available for progressive MS. And the question would be, is that because things have been tried and they don't work, or because no one's trying?
So that's from a combination. In the past, we have had trials in secondary progressive MS, for example, more recently deruxtecan, and then primary progressive MS like rituximab. Unfortunately, they have been negative. It may be because we didn't study large enough patients for long enough, and we didn't study them earlier on in the disease. So I think those studies have not been in vain. Those studies have taught us how to do better studies in the future. And at the present time, one drug, fingolimod, that we talked about, is currently being tried for primary progressive MS. Enrollment is still open, but I have a feeling in the next 6 months we'll be fully enrolled, which means in a couple of years' time we'll know the study results from that. The Tysabri in secondary progressive MS may be a study coming to us very soon. And then in progressive MS, I think some of the research has to focus on better symptom management, because there's lots of symptoms that patients have. How do we better manage those symptoms? So famotidine is an oral drug that is useful for walking speed, and so that might be helpful as well. But it's not for lack of trying. But remember, MS trials are extremely expensive, and because primary progressive MS is a small percentage of MS in overall numbers, there have been less trials in that field.
Thank you. And I'll ask a follow-up question that has come as well with respect to famotidine. Could you tell us when you think it will be approved? And the question is, can it be taken if you are also receiving Tysabri injections at the same time?
Okay. So the last part of the question is easy, and that is yes, it can be, because they do two different things. Tysabri is a disease-modifying drug, reduce relapses, reduce lesion accumulation on MRI, and reduce disability. It's not for symptoms. Whereas famotidine is a pill that is useful for symptom improvement. And the primary endpoint of the famotidine study was walking speed. So you walk a little better, it lessens spasticity, and it may possibly have effects on other symptoms of MS, so further studies will show that. As to when it'll be available, it's already been approved by FDA in US. There's some talk about it may be available by February, March, but I don't want to preempt what Health Canada will say, but in the next 6 months or so.
Thank you. And I'll just carry on with the progressive theme for one more question while we're sort of in that area. And for Dr. Knox, if Dr. Zamboni's study showed that there was no benefit for people with progressive disease, why are people with progressive MS now talking about benefits when they've gone overseas for treatment and come back and feel better?
Thank you. So that is correct. In the progressive group, there was no improvement in disability, but there was improvement in the quality of life outcome measure, the physical and mental quality of life. And there are many factors that influence quality of life, many of which we do not fully understand. And so it is possible that patients feel better after an interventional experimental treatment and function better related to quality of life.
Okay. A question, I think, for both. I'm going to ask it specifically for Dr. Bond, but really, Dr. Knox, will need your assistance with this as well. The question is whether the MS clinic in Halifax is going to proceed with testing for CCSVI in the near future. And perhaps we can expand that to just say, can we get a sense of what currently is underway around CCSVI research in Canada and where things might be headed.
So I think the preamble should be Dr. Knox's presentation, understanding that veins are not arteries. So the impression that angioplasty is being done all the time for the heart and sometimes for carotid arteries, why not for MS, is because arteries are like hose pipes. They are stiff structures that can withstand angioplasty. Veins are thin structures, and so that's one problem. And the second problem is that we don't, as Dr. Knox has shown, that Dr. Zamboni showed CCSVI present in 100% of his 65 patients, but every other person after that gives us different numbers, and it's down to about 16%. In fact, most telling is Dr. Zavadanov's findings, because he sent his ultrasonographers to Ferrara, Italy, to be trained under Zamboni, so he's doing exactly the same methodology. Now, in his hands, when 500 patients were studied, 56% had CCSVI, 24% of normal people had it, and 44% of other patients with other neurological diseases had it. With all of this confusion, how can we move forward with an angioplasty trial? We cannot. So we have to first answer the two pivotal questions, and that is, number one, is it true that most MS patients have abnormal veins? And number two, what is the best test looking for abnormal veins? Is it ultrasound? If it's ultrasound, how should it be done? A typical artery ultrasound takes about 5 or 10 minutes to do. Zamboni's protocol, described in his paper, takes an hour and a half. How reliable is it? How valid is it? Is it an MR venography, or is it the dye test catheter angiography? So for those two questions, we currently have 7 studies funded by the MS Society of Canada and the National MS Society in the United States. 4 of these studies are in Canada, 3 are in the United States, and all are looking at the same question. I happen to be part of the international panel that looked at the grants that came in looking for these for the funding for these studies. And these 7 studies were chosen because they were the best and they complement one another. For example, Dr. Benwell's study in Toronto looks at children. And if it's true that patients are born with abnormal veins, what better population to study than children? So these studies that are ongoing will take 2 years for us to get the answer. And if the answer is yes, that CCSVI is more common, this is the best way to do it, I am prepared to move forward at that time.